All right, thank you all, Jesse, Furman, Nathan, and Jennifer, for a great discussion. Really appreciate the concrete steps. You heard starting this morning from Al Kellerman about how daunting of a situation emergency care can be when there isn't collaboration, when there aren't these constructive steps taken to deliver acute care much more effectively. It can seem pretty overwhelming and daunting, but the first panel certainly identified some effective ways to move forward on through clinical leadership on improving care, and I think our challenge is getting this from being the exception to the rule. So I'd like to get our second panel up to help us start talking about how to support these kinds of efforts. I think the way that Nathan put it was, gosh, there ought to be some ways, some simple ways Nathan mentioned, to get more resources behind these opportunities for shared wins in acute care. I do want to highlight, since we're going to be talking about payment and other policy reforms to support acute care transformation in this panel, I do want to highlight the fact that there were payment drivers, threats or constructive ones, that provided important support or important impetus for some of the reforms that you heard about before. In Maryland and in Upper Chesapeake, this is a hospital that had been subject to the Maryland hospital financing reforms, which placed this hospital system on a fixed budget and therefore a more acute need to limit hospital resources and use them effectively in ways that probably weren't the same, created the same kind of pressure under fee-for-service or admission-based reimbursement. In Washington, you heard eloquently from Nathan about how the whole approach there shifted from antagonistic and approach to one of building trust, to identify ways to address challenges effectively through collaboration. And in Colorado, you heard about how the initial CMMI grant has helped launch this program, but there is a need for a shift to payments that are better aligned, that are more integrated to support things like primary care, case management, working with the ED on the highest risk, most complex patients. As you heard from Jennifer, a small PM, a small payment for each patient each month is probably not enough of a shift. In this panel, we're going to be hearing from some people who are very much involved in different kinds of financing mechanisms and new approaches to supporting and sustaining and expanding the kinds of care reforms we heard about in the first panel. So pleased to welcome Brendan Carr, the Assistant Secretary for Preparedness and Response for the Emergency Care Coordination Center at HHS, Dave Marcosi, the Senior Advisor for Emergency Preparedness and Acute Care in CMS, where he's involved in some of these kinds of payment reforms and care transformation issues, and Jeff Sullivan, the Senior Advisor for Southern California Permanente Medical Group at Kaiser, a group that has a different approach to financing emergency care, acute care in a more integrated way. We're going to start very much like on the last panel with some opening comments from each of these perspectives. And Jeff, I'd actually like to go to you first. Maybe you could tell us a little bit about how financing works in Kaiser. Everybody knows it's an integrated system with more comprehensive capitated financing in Kaiser, California, but maybe with a specific emphasis on what that means for financial support for acute care reforms and how those might be relevant to some of the many healthcare organizations that are delivering acute care but aren't nearly as financially integrated as Kaiser. So start with you.
Thanks, Mark. I'm Jeff Sullivan. I'm a retired physician executive with Southern California Permanente Medical Group. My clinical specialty is emergency medicine. My board's in emergency medicine. And my comments are going to be based on my almost 4 decades of experience with KP and don't necessarily reflect a public policy opinion of Kaiser Permanente itself. I also want to thank Brookings for hosting this really neat event and acknowledge Dick Merkin's contributions. Dick, if you may or may not know, also had a beginning in emergency medicine as long ago as my beginning was. My comments are going to reference a study that was just recently published, Jesse, Myself, Wes Fields, and Dana Kinderman Sachs published an article which was based on Kaiser Permanente, California, Northern and Southern California regions, which are hospital-based. 37 hospitals at the time that we did the study in California. And my emphasis will be on the Southern California programs, though Northern California region has similar programs. I'm just more familiar with the Southern California programs. As we reported in Population Health Management in the last month or so, in 2011, we looked at publicly reported data for ED utilization. And what we found is that the California regions of Kaiser Permanente had much lower utilization than the state as a whole, the 38 million population of California, and even lower than the United States as a whole. 244 visits per 1,000 for KP, 334 for California population, and 418 for the United States. They also, the Kaiser Permanente system, had a lower admission rate, shorter lengths of stay, and lower readmission rates, 90-day all-cause. I expected some skepticism, and so what I also wanted to do, and what we included in the article, is I looked at, first of all, the population. With the KP members healthier? And you can't compare commercial populations, but you can seniors, Medicare risk scores. 13% of the members are senior Medicare Advantage in KP. Northern California was at parity. Southern California was a little bit healthier, but not healthy enough to explain the differences. I also wanted to look at financial barriers to care. Did KP members have impediments in seeking care because of financial barriers? In 2011, 86% of the Kaiser members in California had no deductible, only copays. 95% had a copay of less than $100, and the actual copay of ED visits was in the 40s, $45, $50. So I don't think there were any financial barriers to accessing care. And then the last question, what were the outcomes? Were people suffering as a result of denied care? And what we found, in fact, was the exact opposite. And in the publicly reported outcome studies, the Medicare 5-star ratings, the HEDIS, the Leapfrog, NCQA reports all show KP at the top of the quality in the state. So the question is why? What is going on here? My opinion is the emergency department visit is simply a symptom. ED utilization is the metric that you would use to gauge that symptom. But the disease really is misaligned incentives that prevent actual integration, true integration. And you end up driving inefficient encounters because they're financially rewarded. And when I distilled this all down, what I found was I found 6 attributes to the KP system that I think make the integration really work. And I have to tell you, if you ask a busy emergency physician at 3:30 in the morning about my 6 descriptors, you may get an anatomically correct response that may not be embraced. But at the front line, these aren't embraced motives, but in fact, this is how it really works. The first is there is true financial alignment between the payer, the provider, and the hospitals. Secondly, there's shared risk and cross-subsidies between all 3 entities. Third, the system's prepaid. No incentive for overutilization and actual contractual disincentives for withholding of care. Fourth, the medical groups are multi-specialty and self-governed with complete authority for all decision-making, clinical decision-making. Fifth, the physicians are all part of the same medical group with the same strategic goals. So whether it's the emergency physician, the hospitalist, the specialist, the long-term care physician, the pediatrician, they're all with the same strategic goals and outcomes. And sixth, the physician compensation is primarily salary, with incentives for quality, for service, and for some financial efficiency of the organization as a whole. So as you sum this all up, I think that as it applies to emergency medicine, but could apply to any specialty, the emergency physicians are the critical piece in this continuum of care that begins at home, before the patient even knows they need emergency services, to home health care at the end, or the nursing home at the end. Most non-PMG physicians or emergency physicians are incented for utilization. The stuff that's really valuable are the patients that aren't being seen. And there needs to be a way to measure that and incent and reward for the patients that don't end up in the emergency department. It may have implications on the scope of practice for emergency physicians and the integration of emergency physicians into the hospital and into the medical groups. And in the end, this may in fact imply that it would be better for emergency physicians to see fewer patients per hour at a higher cost per patient, but lower total population cost.
Thanks very much, Jeff, for that overview. I think I'll actually go to Dave next, if you don't mind, and just pick up on some of these themes we've been hearing about. So, Dave, I know you've got your own direct experience in emergency care and dealing with some of these challenges in acute unscheduled care, dealing with the issue of getting the right patient with based on their level of acuity to the right efficient setting, and also dealing with the need to align financial resources to support that, as Jeff talked about in the Kaiser context with your experience at CMS. So maybe some opening thoughts on these issues.
Yeah, thanks, Mark. And I want to just thank Jesse and you for hosting this. I'll be a Fed for 2 seconds, and I want to certainly give regards from Dr. Patrick Conway, the Deputy Administrator for CMS, a true leader and a health innovator. And then take my hat, and Dr. Sherry Ling, the Deputy Chief Medical Officer. So they're really quintessential with thinking about how health delivery is going to occur and evolve through the next few years. With that, I'll take my federal hat off. My remarks don't represent the Department of Health and Human Services, nor the Department of Defense, nor George Washington University, nor my mother. So with that disclaimer that I think every lawyer in the room would be fine with, I'll move forward. The way I think about emergency delivery of care, and it really echoes and it's woven through a lot of the remarks with the folks that have delivered their statements before and their comments before, are three things. So it's 3 C's and a D. It's criticality. So patients still get sick. Patients still get injured. Patients are still scared. And what do you do when you are in those conditions? If you're critically ill or critically injured, you dial 3 numbers on a phone. And someone answers that phone 24 hours, 7 days a week, and someone arrives to your door. And if we were to go down right now, we would have those kind of concerns. And then you would be transported to an emergency department that is open always, that is always ready, and unfortunately, due to some financial perceptions, always expensive. So the question then is, how do we coordinate that critical care piece to align incentives and better delivery of care? The second C is around convenience. Folks that I see in the emergency department, and certainly stats back that up, demonstrate that they come to the emergency department because it's 8 o'clock and they get off work and they have to take care of their children. And their primary care physician is no longer opened. But you know what? I have a sore throat and I want to go back to work tomorrow. Can you help me? Or I'm sick and coughing, or I have abdominal pain. And can you help me right now because I want to go back to work tomorrow? So there's a convenience factor that emergency medicine is not appreciated for, and that piece is critical to how we deliver health care for our nation. The third C is connectivity. Because the truth of the matter is, if done right, emergency care connects with who? Specialty care, toxicologists, social work, public health, law enforcement in the case of domestic abuse, psychologists, community resources, for one patient every time if done right. So be able to get the time to be able to devote to that patient to get that connectivity of care right is important. Those are the 3 C's. The last is a D, is disaster preparedness. And what we do today right now for our gunshot wound, for our stroke, for our heart attack, affects what we will do for the next national crisis and disaster. If we can't do it right now, then we won't do it right then. So it's important to buttress that emergency care system to get it right, to get it more efficient. So that when we are stressed due to a national, local, or community crisis, we can actually affect care more importantly during those critical times of disasters. I'll end with 2 other pieces. The first is IT. The IT systems to support when you dial 911, our EMS system, our emergency care system. To quote one of my emergency care colleagues, it is a clicking nightmare. You spend more time at the computer than you do at the bedside. And regardless of the IT system you use, and I've used 3 currently, I know, and I've used 3, it is a concern. And for when time-sensitive conditions have to be spot on, you have to be accurate, you need to be bedside and not at a computer. And this nation needs to embrace better, more efficient ways to execute IT in and around time-sensitive conditions in the emergency department and for EMS. Lastly, is the piece around, I'll leave that to subsequent.
All right. Well, you're on a roll. So let's make sure we do come back to that, Dave. So, Brendan,
getting the flag. So.
That's quite all right. We have plenty of time for a discussion here. Very important issues. And Brendan, one of the key points that Dave highlighted was around disaster preparedness. I know this fits with some of your current work, but I'd appreciate your thoughts about how that fits in with this broader push to try to better align support for what's needed in acute emergency care with the critical functions of emergency departments and our acute care system more generally.
Thanks so much. Again, thanks, Mark, Jesse, all of you at Brookings for hosting us. Although maybe I should just soak in it for the moment, I should probably say first that I'm not the Assistant Secretary for Preparedness and Response. I bring Dr. Laurie's hellos. So I am the director of the Emergency Care Coordination Center, which is within the Office of the Assistant Secretary of Preparedness and Response. And it's a great privilege to serve in this role. We have a mission that has 4 pieces to it. The first is to lead the U.S. efforts to develop a patient and community-centered emergency care system that is integrated into the broader healthcare system, that is high quality, and that as a result of those 3, to your point, Mark, and to sort of building on what Marco said, what Dr. Marcosi said, is that we are then prepared. So if we're doing everything right in the day-to-day, we will be ready, as my boss likes to say, on game day. So as the director of the ECCC, I'm lucky to do 2 things, which I'll highlight today. The first is to be the convener of all the federal partners that have a dog in this fight. The Council on Emergency Medical Care are all the folks that think about emergency care delivery, and these include folks from within HHS, of course, but across the federal government. And the second piece, which is a relatively new piece, is, Jesse made reference earlier to the delivery system reform initiative that's happening internal to the federal government, sort of chaired by CMS, the Office of Health Reform at HHS, and the Office of the Assistant Secretary of Health. And we have, Dr. Margolis and I sit on the advisory panel for this delivery system reform initiative, and there was reference earlier to the learning network, the healthcare payment learning and action network. I hope we'll talk a little bit about that later. So at risk of sort of being a broken, sounding a lot like my colleagues, I should say that I do have a lot of thoughts, and I want to treat this as a brainstorming session, and I don't want these things to be fully representative of ASPR or my boss or HHS. I'm sorry to have to say that, as everyone else did. But I do think that, so here, the crux of it for me is that, just a couple weeks ago, I took care of a woman who had nausea, vomiting, couldn't hold anything down over the course of several weeks, had been to her primary, had started the workup, had some blood work, had an ultrasound ordered and worsened, and now, of course, it's sort of in the evening. She shows up throwing up in the emergency department. Her abdomen's awfully tender. She's got a white count, and she gets a cross-sectional imaging study, and she has what, for all the world, is pancreatic cancer diagnosed in the emergency department. She's having trouble tolerating anything by mouth. She gets put into the hospital, and the hospitalist service. So that, I think that piece of the story is that piece of the story. It is what it is. Who would have thought that this was in a young woman, that disease? The real story is 2 weeks later when I walk into the room and see her again, and she says, or actually her husband says, we just don't know what to do. We called the primary, but the primary doesn't know anything yet because the hospitalist took care of her. We called the oncologist, but they don't have a tissue diagnosis yet, so they're not really sort of in charge. We don't know how to call the pathologist to ask them to call the oncologist to give them a tissue diagnosis so that someone will own our care. I think you sort of, you get how the story goes, but I walked out, I sat down at my computer to, I don't know who I was going to call, one of them, and sort of, explain that this woman needed to be admitted to the hospital again. And I said, being sick in the U.S. is terrible, but getting sick is worse. and of course, my resident, without missing a beat, said, "I'll make you a T-shirt. Can I tell you about 2 more patients?" So, it just does, it sort of, it hammers home this idea that until you are owned, until you are, Mark made reference earlier to asthma programs, right? We've talked about you talked about the oncologic medical home. Until you have your diagnosis, though, no one owns you, and it's an interesting and tricky time. So I wanted to make just a couple observations. Sitting on the inside of the federal government watching, that first panel was invigorating, right? Really, really exciting about all the amazing things that are happening out there. But it does strike me very often that these things happen within this game. I don't know how exactly to be part of the conversation. So I sit next to, although not representing Kaiser, someone who comes from, a health system that's taught us all a whole lot. But I don't know that health systems define for us, for most people, the way they think of their community. So if you happen to live somewhere where there isn't a health system that has a giant market share, I worry a lot that we don't connect the dots very well. The second thing that I wonder what the solution to that is. I hope we'll talk about that. The second thing that I think a lot about is these, the advanced payment models, which the Secretary Burwell has sort of acknowledged we are going all in on funding. They are built, I think appropriately built, around primary care, chronic disease management. That's where most of the money is, or most of the expenditure is, and it sort of is a key piece of a key building block here. But emergency providers aren't in there yet. And most recent numbers I saw, and I don't know the methods deeply enough of this survey because they weren't available, but was that 15%, even within an advanced payment model, 15% of the emergency physicians are in some sort of novel payment model rather than just fee for service. That's a low number. We need to think about how to integrate and how to make this a team sport better, and I think that's a conversation that we should have moving forward. And then the last thing I would say is that, and this has been said before, I think by 2 others, someone said canary in the coal mine, and Dr. Kellerman said room with a view. I worry a lot about the narrative that we've created around emergency care, and I worry, especially when I hear it internally within the federal government, that there are 2 ways to see this. Nathan had it perfect, and of course I didn't write it down, but he said it's the convergence of all failed policies or something of that nature. That's an interesting thing. That narrative means we can go one of 2 ways here. We can say that, that we have failed you and this is our problem, or we can flip it the other way and make this be about the inappropriateness conversation that has been going on for some time in the U.S. I don't think any of us actually want to blame patients, but I do feel like we sometimes slip down the pathway of talking about people inappropriately using a resource when really what I think they have told us is that we've not built the right system to meet their needs. So I look forward to a conversation about solutions, specifically about population health, which I know is one of the things that we're going to talk about.
All right, great. I'm going to push you all on those solutions starting right now. And maybe I'll begin, Brendan, by picking up on the comment that you made about the fact that there is a lot of payment reform going on now with the intended effect of getting to more effective and appropriate use of acute care generally, but most of that doesn't seem to involve emergency departments and their physicians directly. So as you mentioned, there are a lot of medical homes out there that are starting to do something different. So when their patients, especially when they're high-risk patients, call them up, and sometimes they have special numbers as well as case managers. If they call them up after hours, they don't get the message. If this is a medical emergency, hang up and call 911. They get a nurse or a physician on the phone right away who knows them, who can help, in many cases, avoid those ED admissions and avoid the costs associated with it. But much of that is happening without the ED physicians involved. And you highlighted in your comments that for many patients that aren't already part of one of those high-risk patient networks, those resources aren't available. We heard earlier about in the Colorado example where one of the maybe the best ways or a good way to identify high-risk patients is by working with EDs and seeing which ones are coming in often and then using that connection to place them into a more coordinated system. But again, that requires resources. So I guess I'd like to push you all on what these alternative payment systems might look like if they better include emergency physicians and emergency departments. This would both help address, I think, the problem of EDs being engaged in coordinating care for these high-risk patients, the opportunities to do so, but also you all have highlighted some of the potentially beneficial financial impacts of getting patients, as we were hearing earlier, with a rash or a diaper rash who gets very little reimbursement on Medicaid, getting them out of the ED. But conversely, a lot of these lower acuity patients who do have good coverage and are now being treated elsewhere have perhaps negative financial implications under a fee-for-service payment system too. So, Jeff, maybe you could start with you. You've got experience with the integrated Kaiser payment system, we just heard about. That's not most of America. Or there's some steps, some key steps in the direction of that kind of more aligned payment that you think are feasible for organizations that are currently much more fragmented?
Yes, and I actually think it ties to the question that was asked in the previous session. The KP findings in California, we had almost 7 million members at the time that Jesse and I did the study. So it's not a small group sample that may not be replicable. It's 7 million is enough to know whether or not ED utilization is appreciably different. And it's the alignment again, because the alignment of the payer, the medical group, and the hospitals are all going in the same direction. That's the magic. You can't do 2 out of 3. Integration is a word that is bandied about all the time, but integration doesn't equal consolidation. They're different. And when you talk about it, where's the role for the emergency physician? I think in the current models with CMS, both the Medicare Advantage program and the Pioneer ACO models, for the first time you have an aligned payer. Now you need to get the hospitals and the doctors to come to agreement. And the emergency physicians it's a systemic disease. The ED visit is in many instances a failure of other systems that should have taken it, whether it was secure messaging or whether it was telephone advice or whether it was the primary physician responding. The patient ends up in the ED. There are ways to avoid that, but only if the emergency physician is part of that continuum. And whether the ED discharged to the orthopedic surgeon the next day or the ophthalmologist or whatever it is, or directly to the nursing home, if the emergency physician isn't in that continuum of all the providers and the need for the visit before the patient leaves home isn't addressed with the systemic approach so that everybody is pulling on in the same direction on their oars, I think that the 2 models that we're seeing with payment that may be able to accomplish that are the Pioneer ACOs and Medicare Advantage, only because now you have a payer that's not indifferent to the actual outcome and utilization.
That's an overall payment to a group of providers that are now sharing accountability, and that is something they could potentially use to shift the resources in the direction of coordinated care. But Dave, Brendan, if you all could comment as well. You all both highlighted the lack of resource support for care coordination, time spent. Brendan, you went through a long list of things that ED physicians often need to do, especially for those patients that aren't yet part of one of these systems. We also heard about the limited resource support for effective information sharing. I'm not talking about the 30 clicks on the electronic health record system, but something like those 3 key data elements that we're hearing about from Nathan, that if you knew those, even those basic things, that's going to make a difference in care, but not good resources to support that.
Dave, can I go first?
Go.
So, I think it's not, the program doesn't come out of ASPR. I mean, the program comes out of CMS, and I'll defer to Dave to talk about it, or primarily out of CMS, but it's the program that I mentioned before, this Healthcare Payment Learning and Action Network. And folks, I imagine this room knows what that is, but for folks who don't, the premise is relatively simple. It is, I think, the beginnings of the conversation that this panel just called for, which is to say, there's really exciting stuff happening in some of these new payment models happening out of CMS. You have an invested payer. And this network, what it is the federal government asking other payers to come to the table, to convene, and to have a conversation about how they can all get on the same page, so that I don't just do the right thing by my Medicare patient, whatever I'm building for my Medicare patient with respect to their care coordination or their social services or nursing home placement, whatever it might be. Those same sort of incentives can be aligned with other payers that are dominant in my market. So that's, I mean, it's huge, and it's a conversation that's just started. The kickoff was maybe a month ago, and the conversation is just beginning, but it's a really, really big deal. I wanted to just sort of say one other thing, which is, it is interesting. You're right. When we talk about patient-centered medical homes and the innovative things that are happening in a patient-centered medical home not working collaboratively with the emergency department, and that as a perhaps a problem, certainly an opportunity. The other side of that coin, which we have to be really thoughtful to make sure that we remember, is that the emergency care community has also, this is not entirely the emergency care community. Many in the emergency care community have been players in creating freestanding emergency departments, urgent care centers, things of that nature. And so where the intersection is between the patient-centered medical home and whatever your feelings are, and people have many, about urgent care centers and freestanding emergency departments, there is really a convergence there to think that there is a way to integrate these two solutions that two sort of separate communities created. One was, well, I do condition-specific treatment. I will do that in a lower-cost environment if you want me to. And the other was, well, I coordinate care. I can do that with a telephone, since I know you can check my electronic health record and keep you out of a high-cost center. And then the telehealth thing we didn't even talk about yet, and the idea of using new providers and community paramedics we haven't talked all that much about yet, although it came up. It's a bit ready to tip, I guess, is sort of where I think we are, but we need to align the players.
Yeah, 3 C's and a D. One of those is connectivity. So we're speaking about connectivity here and care coordination. The more you involve the emergency department and the physician, the less likelihood that patient will be a bounce back, will be more expensive to the healthcare system, and the more that they're able to connect and find out when are they going to their primary care physician and how they're getting their medications, so that they don't have exacerbations of disease and come back to the emergency department. I think that there's 2 ways to think about this, Mark. I think that there's a way to bundle payments around care providers to incentivize them to work collectively together, and that includes emergency physicians and emergency departments and EMS. We're seeing a lot of good work in EMS with telework and them going out in community paramedicine, going out and actually working to be another force multiplier for care within a community. So that's also key. But there's another way to do this, and I think it's around measurement. And when there is a measure that changed the way we think about acute cardiac care for the nation. And the measure that CMS put out was, and Joint Commission around, the door-to-balloon time measure. So when the measure came out, that means, wait a minute, that's too hard. EMS needs to coordinate with an emergency department, needs to coordinate with cardiology, needs to have an open cath lab. Too hard, can't get there from here. Not only is it standard of care for the nation, when you dial 911 and you have a heart attack, that you'll get to a cath lab quickly, or not only is it standard of care, but the standard of care is 90 minutes. The average length of time is less than 60 now. So it is fascinating how we pivoted a nation around acute cardiac care from one measure. So an equivalent to that would be, for criticality, my first C, around show me the measure for trauma care. Show me the measure that we can actually utilize for stroke care, for pediatric care, for mental health. And the burden of mental health, when you have an acutely schizophrenic person in the emergency department, patient, and you're trying to dispo that patient, potentially the worst place after acutely stabilizing that patient is in a chaotic emergency department. And where do they sit for 4, 6, 12, 24 hours? In an emergency department. And that's just not acceptable. And I think we can do better at that. And as a nation, we can think about a better measure to incentivize and align incentives around better care for those folks.
Yeah, let's stick with this issue of measurement, because it does seem like it's a critical step in getting to this better alignment of resources with the goals of care. And it was important in all of those examples that we heard about earlier, measures of some obvious things like ED visits and hospital admissions. That's something that many health plans are now tracking, and obviously concerned about, measures of cost. But as you highlighted, Dave, we really don't have a whole lot of measures that capture key aspects of how emergency care can fit in with other providers in delivering acute urgent care effectively. So I'd appreciate any other thoughts that you all have about what we ought to be focusing on. I think door to balloon time for patients who have heart attacks and the like is a good one. It has created that pressure to recognize the importance of pre-hospital care, what happens with the emergency response system, what happens in the ambulance and the like. Are there other measures like that you think would be good to help capture and help create similar momentum for other transformational changes involving acute care?
Did I take a swing?
Sure.
So, I think we need to step back just even a little bit from there. And I worry about how we define our denominator here when we're thinking about unscheduled care. Because, if I'm a cancer surgeon and I operate on you, I should own your outcomes, probably, marching forward. But I don't know that the same argument it should exist or can exist for unscheduled stuff. So I may travel to meetings in different parts of town today. I might live out in the burbs, and if I wreck my car at some point today, I'd like to know that the community on the whole has some responsibility for making sure that I have a good outcome. So let's talk about a hard outcome. We're critical of process outcomes. Let's take a hard outcome. We know the literature tells us that treatment at a trauma center, if you're severely injured, markedly improves your survival. But the dirty underbelly of that is that about half of severely injured patients don't get treated at a trauma center. And in fact, one of the big risk factors for not being treated at a trauma center is having good private insurance. So I worry a whole lot about when we allow our denominator to be gamed, and by game, I don't mean game in some malicious way. An accountable care organization, even Kaiser, right? They care for Kaiser patients. My hospital, my health system, we care for our health system's patients. We haven't won this game for unscheduled care until we have created an incentive and the measures that go with it that reach across the whole of the city, so that as I travel today, I know that both, I won't name names, but all of the big health players in the city are very worried about making sure that I have a good outcome should I roll my car. So, I think, I'll just sort of end with this, I think the answer is out there. I don't even think the answer is very hard. I think that the patients tell us the answer by the way that they use healthcare resources. It is just math. It's even really easy math to look at how Medicare beneficiaries cluster around hospitals to identify what they're telling us is our responsibility. They are defining a community, and I think that community could be held accountable for the unscheduled outcomes for those folks. It's not the way we think. It's a big pivot. You would have to make competitors cooperate, and competition is not something we're very good at in healthcare.
Maybe not overall, but as you pointed out, there's some aspects of acute unscheduled care that really are best handled as a community level responsibility, and as you do not in your job as assistant secretary, but in your critical role in emergency preparedness. These are the kinds of things that you want to track, right? I mean, what is a community's capacity to respond to acute emergent needs?
What's the accountability of the non-trauma center to transfer a patient to the trauma center? What's the accountability of that trauma center to make sure that best practices are in place in the non-trauma center?
Yeah, I tend to look at it more from a population perspective. I'm interested in utilization per thousand population. I look at emergency department. All of us who have practiced in emergency medicine know that there's a large percentage of every day that we're seeing patients that really didn't need to be there if there was some other way, some other system that could have helped them. All that we would want for our families. I look at ED visits in that sense as turbulence in what would otherwise be laminar flow in an entire system. And so I look at the utilization, but I look at the outcomes for the population. And so whether you're using hospitalizations or readmission rates or mortality or morbidity, and I think to go upstream is the way to address this, and that's with disease management, like in Southern California, for instance, our congestive heart failure program track people with a disease that is likely to lead them to the emergency department unexpectedly and then you'll end up seeing them, but treating them proactively before they get into congestive failure while they're at home, tracking them, monitoring them daily. Those are the sort of initiatives that prevent emergency department visits, but in fact have to be valued. And right now, they're in the current payment methodology, you incent utilization, you incent visits, and that's what you get.
Yeah, so I think that you have good providers, nurses, docs, EMS providers who are trying to do the right thing in a very fractured and fragmented system. And that's a challenge. So you have the best ER doc who just can't get the information, the best paramedic who's not quite sure what the story is and where to go. And unfortunately, I think that the challenge is that we're confined by economic construct. So we have an IPPS that's the hospital-based. We have an OPPS and a financial system for that, which is either A, hospital-based, or B, for the physicians. And then C, we have a completely different construct for EMS. When in essence, if you dial 911, and from a patient-centered standpoint, if you speak completely independent of Fed speak, and actually speak very practically about it, the patient calls 911. He enters the he enters the ambulance. He goes to the emergency department. He then sees the pick a specialist if needed, and then goes to the operating room. This reason we are fragmented is as a result of the financial stovepipes that we've put in place, not, and everyone speaks to patient-centered focus. Well, I would say that if you want to change the system, not just evolve, but actually pivot it, we would actually be patient-centered, and economics would follow a patient-centered construct and not be confined by the financial construct that we currently use as a nation. I think there's better ways to do this. I think Brendan spoke to a piece of that. How does a community come together to when I have a STEMI or a heart attack, and I am down in the mall walking around and I collapse? Tell me how those 4 different hospitals come together, work together with EMS, public health to affect that care so you get better outcomes. That's a pivot, and that's a change.
It is, and that may be one reason why this has been a little bit harder. Again, going back to Nathan and keeping it simple, it's been a little bit harder to involve emergency care. We heard earlier about some steps with the hospital payment reforms in Massachusetts that were leading to hospital-based initiatives to address some of these challenges. We heard about the pressure in Washington that got the healthcare payers together with the emergency providers to work more collaboratively on information sharing and the like. But as you said, Dave, this really does, because it does involve so many parts of our healthcare system, inpatient payment, outpatient payment, physician, EMS, though that is a bit heavier lift. I mean, I want to open this up to discussion, but just I don't know if you have anything that you could add quickly at this point. We heard about one CMS initiative, the Healthcare Payment Learning and Action Network, that's intended to bring together a number of these different parties to find collaborative solutions. Congress just enacted, finally, an SGR, Sustainable Growth Rate payment reform, which includes a big push towards alternative payment models for different kinds of providers. Haven't seen much there yet in the emergency physician, emergency care area, but it seems like another prime opportunity for this kind of progress.
Yeah, so I'm not a Fed right now, so speaking not on behalf of that, I think that we're trying to, the next steps around how SGR will be implemented and the application to what physicians think about around how they get paid and linking that to performance, linking that to outcomes could be fruitful to better care coordination. I don't think we achieve a truly contiguous system and continuous system of care delivery unless you understand from the time you enter the emergency department, the time you enter a hospital, which is largely now through an emergency department, all the way through to rehabilitation. Unless you get the front door involved, then the back door still fails. So it's better, we are better suited as across the continuum to include emergency care. Will be better as a result of it than if we omit it.
I'd like to open this up to questions and comments from those of you here in the room, and again, anyone online can use that hashtag MedTalk to get engaged too. So if there are any questions, please hands up, and I'll try to get the microphone to you quickly. So back here first.
Sandy Schneider from the American College of Emergency Physicians. This is specifically to Jeff and from Kaiser. We've heard the emergency department called the most expensive care. We've heard about our role as the failure of the healthcare system. And when the financial systems are, shall we say, more aligned together, and when that's taken off the table, how is emergency care viewed at Kaiser? Is it viewed as the most expensive care, or is it viewed as an opportunity to improve the care of patients?
That's a great question, and the answer is when I was in my executive position before retirement, I looked at it holistically. I mean, the emergency department was just one small integral part of a continuum of care. Hospital utilization, our bed day utilization is actually quite good. So the ED, I'm confident in Southern California, and I think in Northern California also, that our cost per visit is probably much higher than the community, and our visits per hour, or however you want to measure emergency physician productivity, is probably lower. But more time is spent than sorting out the patient in the ED, observation units. Consultants are generally available in-house. It's a cross-subsidy. The medical group is paying for that to avoid the admission of an insured patient in a private hospital. And if you think of how odd that alignment is, but it works. And so the throughput is probably slower. The intensity of the care and diagnostic resources brought to bear are probably greater. And the consultation, the net result is a more expensive visit, but a total system cost that's probably much less. And then you have to go upstream, because the telephone advice nurses that are available 24 hours a day, the secure messaging, all of the other pre-ED systems that the health plan and the medical group and hospitals support mean that we've already filtered out a third of the patients that are being seen at other EDs in California. And in California, about 20 to 25% of the ED visits are non-KP members. So, I mean, that's mixed in with this, but that's a great question. And my plea is to look at it holistically.
I mean, that does suggest a very different payment model. If the patients who are there getting acute unscheduled care in the Kaiser EDs are these higher acuity patients that cannot be handled effectively through the other alternatives you set up, whether it's phone, telemedicine, office visits, other acute care settings, they are going to be considerably more intensive patients to treat. So you've got a much higher cost per patient, but a lower volume of them, which is sort of the opposite of the way fee-for-service tends to work, which is, keep trying to lower the price and increase the volume.
Mark, how do you value the patients you're not seeing?
Yeah, and that's back to the key point that you made, and that gets back to the financial alignment goals. Yeah, over here.
Hi, I'm Dr. Caroline Poplin, a primary care physician. Again, I'm concerned that I'm hearing a lot about aligning financial incentives and integrating large organizations, but I think one of the points that was made in the first panel was interoperable EHRs. So that when somebody comes into my EHR from out of state, I know that he had a cath 15 months ago, and I know what it showed. Now we don't have that, and you haven't mentioned in the incentives and the payment reforms anything about making information systems interoperable. And stage 1 and stage 2 of meaningful use had very little about interoperability, and now vendors are at all different hospitals and ERs, and they want you to use their system. They don't want you to use some other system, because then they might lose a customer. We haven't heard anything about financial incentives for that.
So let's talk about that.
Well, within KP, obviously, we have total interoperability. Another example of cross-subsidy, the insurance company, the health plan, put the $4 billion or more into the system for the physicians and hospitals to use. But you're absolutely right. And one of the things I did about 20 years ago is I developed a program. It's called the Emergency Perspective Review Program. It's based in Downey in Southern California. And we have permanent physicians and critical care nurses there 24/7 by 365 with access to all of the clinical records. And that service is to provide information to non-Permanente, non-Kaiser hospitals. When a KP member ends up in a non-plan hospital, the emergency physicians were dealing with the same problem that we've all dealt with. Single 800 number, direct answer, and everything that's ever been done on that patient can be read over the phone. Can't fax it or email it because of HIPAA, but you can read the information to the treating provider and then address that. That is absolutely essential to quality and outcomes and expense, because you repeat stuff if you didn't know it was already done.
Now, this is, I do want to keep pushing on this, but outside of the Kaiser context where you don't have a fully integrated electronic record, which is still most of the country today, we did hear earlier about the Washington version of what you were just describing, Jeff, about sharing critical information. Who is this patient? Where have they been? How can you connect them back to care? Those kinds of things. Doesn't require a fully interoperable electronic health record. Does require some resource support to put it in place, but can be done. Seems like there are a lot of opportunities even in the short term to help improve access to critical information to coordinate care.
Yeah, your debit card my debit card works here.
Yeah, almost anywhere.
Yeah. I mean, we draw the same analogy. I was just ready to say that. So yeah, if we go, it's amazing how financials we have it right. But for the delivery of healthcare, we potentially are still. So you can walk in with your debit card into any ATM with any bank. Fascinated by that, but yet when you come into any emergency department and you're really sick, or you go to a primary care physician and you're ill, and what happened to you? We don't have that kind of care as a nation. We don't have that kind of connectivity woven through when I use language around connectivity, around coordination, and those C's that I mentioned, is integral to that is health IT, and that's a way I think needs to be championed moving forward.
Well, see, this part of the SGR repeal is this new thing, right? We'll see if we like this when it comes, the merit-based incentive payment system, MIPS. And so I just think now's the time to lead. So I'm 100% with you that interoperable data changes the way that I can practice medicine, because it's brutal to call some hospital at 3 o'clock in the morning and ask for records to be faxed over. They do show up sometimes 3 days later. They don't happen in real time, and it doesn't help me with my decision making. So real-time data, if you're talking to the emergency care community, I think there's zero question they are all going to embrace it. But I think we need to think bigger than that, right? I want to know, not just did this person go to that doctor, what meds are they on, what are their allergies, and when's their last cath or CAT scan of their abdomen. I'm Philadelphia-based, so I'll use analogies that I understand. I want to know when I'm working in my emergency department, if the emergency department at the academic medical center that we don't even talk to on the other side of town, I want not access to their health information exchange, but to their some other thing, this exchange for healthcare transitions. I want to know if their visiting nurse, if mine isn't available tomorrow, if their visiting nurse is available to go see my patient and check on their wounds. I want a healthcare transitions exchange. I want us to articulate for MIPS what we'd like to see as our payment modifier. What do you need to participate in regionally to deliver the right care to the patient?
So we're about out of time for this panel, and I always like to end with prediction time. It's going to be hopefully some stimulating next steps or next vision from each of you about where we could be headed. We do a lot of work here at Brookings and the Merkin Initiative on payment reform and clinical alignment, and I have to say it strikes me as, on the one hand, if you look at the actual payment reforms that have been implemented, Kaiser is one, but that's not most of the country. Probably less actually in use in affecting emergency care and acute unscheduled care than we see in many other areas. We've talked about medical homes, we've talked about specialty care and things like that may be helping in some ways but aren't yet integrated. On the other hand, we've heard today about a very long list of care improvement opportunities, about ways to measure, about specific steps that can make progress now, and some real interest in aligning finances and other rules, whether it's HIPAA or IT standards and the like, to support that. It does seem like emergency medicine and acute care in general is kind of on the verge of maybe doing this better. On the other hand, if it doesn't get more integrated into the payment reforms, I do worry a little bit about unintended consequences for emergency care and acute unscheduled care as these changes happen around it. Where are we going to be in a few years? Are you all optimistic?
He's looking at me. I'm tragically always optimistic. It disappoints me sometimes. I absolutely am, and here's the reason why: is because I think that this is the lens that people see their healthcare through. when they have a problem, when they get sick, if the system's there for them or not, they voice that. And we have finally arrived at a place in this country, the creation of the Affordable Care Act and PCORI, and now lots of other efforts to include in the decision-making and the care delivery process the patient's voice. They will make us fix this. I'm optimistic.
I think we're at the tipping point from a fee-for-service to a value-based compensation system. It'll be enormous. I'm a free market guy. I'm not a socialist, but I think that medicine is different, and I think that we're at that tipping point. I think it'll work well for the country, but it'll be very painful getting there, particularly for providers and hospitals. I think emergency physicians generally are not team players, but they are a critical element of this, and they will have to be part of the team. And there'll be the care paths, for instance. It's hard to affect a care path in the emergency department if all the specialists in the hospital haven't been part of developing that to help avoid unnecessary use of resources because they're not being incented any longer to do the stuff. So I'm optimistic, but I think it's going to be very painful.
So, all due respect, I think we are incredible team players because we're coordinating when they walk through the door. So, I'll start with saying that I think there's incredible opportunity, but I am cautious with the future of emergency care, only because I'll ask, what is the breaking point? When is it the next news story of the one person who was found with a bad outcome? Is it a 6-hour wait time for an appendicitis, or is it a 12-hour wait time for the appendicitis, or is it 15? And I don't know if emergency medicine is there a breaking point where all of a sudden the nation reacts as a result of a cataclysmic problem, right? We recognize that health is consuming 1 out of every 20% of the GDP approximately. Well, now we have to do something about it. I'll ask, what's the equivalent for emergency care? So I am cautiously optimistic. It needs to be addressed. I know I want it to be addressed because when I dial 911 or our patients present to the emergency department, they get appropriate care. But I'm not sure that the litmus paper has turned completely blue to green or blue to red to actually incentivize the nation to embrace change in that space.
Well, extremely challenging time in acute unscheduled care and emergency and critical care, but I appreciate the cautious optimism and based on what I've heard from you all today in the previous panel, it does seem like we can get to that much more effective, brighter future for acute unscheduled care. Thank you all very much for joining us today. I'd like to turn this over to Jesse Pines for some final comments. Thank you all.
Good to see you again. Oh, yeah. Jeez.
So thanks to Mark and the panel for your great comments. To finish off today's session, I'd like to reflect on the promise of reforming acute care and how this will no doubt evolve over the coming years. There are a few messages that I'd like you to take home with you today. The first is that delivery reform for acute unscheduled care is possible, and that there are many ways that providers and other groups can come together to improve value. The second is that to push organizations to improve value, the right incentives need to be in place, and providers practicing on the front end need better systems, more resources to address some of the social determinants of healthcare demand, such as poverty and substance abuse, and to have a free flow of information within and across settings. Creating systems that work across time and space is expensive, and organizations need the right incentives to make those investments. Providers also need the right incentives to invest the extra effort to coordinate care. The third message, to realize that acute unscheduled care, particularly emergency department care, as we heard from today, is really the sharp end of healthcare delivery. It is our safety net. It is critical not only for the nation's health, but also its security and ability to respond to public health crises. Pushing out payment reforms too quickly that don't consider this has the potential to cause unintended consequences. Currently, acute care is practiced such that serious disease rarely gets missed. Creating sharp financial incentives that change how doctors practice just to reduce costs has the potential to cause major problems. Efforts to reform acute care by the government need to be carefully designed and tested to ensure that the care is made more efficient, the right care is eliminated, rather than effective care. A great example is reducing variation through the development of clinical pathways rather than mandates to indiscriminately reduce hospital admissions or CT scans. Safeguards also need to be in place in payment reform to ensure that safety net providers such as rural hospitals and inner city hospitals are not marginalized or put out of business. These are key resources in these communities and are often the major employer. Innovation needs to be disruptive, not destructive. Stepping back, what we learned today is the acute care system today delivers high quality, high value care when people get sick and injured. But to repeat what I said earlier, we can do it better and we can do it more efficiently. We need to move our current fragmented, overcrowded acute care system to one that works for people. People want this. Creating this system has to be a shared goal for insurers, providers, and healthcare facilities. People get sick at all hours of the day, night, and weekend, and there needs to be an integrated system that provides the right care at the right time for the right patient. That includes the critically injured patient who rolls her car over at 2 o'clock in the morning, the patient with acute stroke symptoms who walks into their doctor's office on a Monday morning, the victim of a terrorist attack, or a homeless mental health patient with suicidal thoughts. To build this new system, acute care providers and facilities need to be integrated into the broader continuum. We need to have the information to make cost-conscious decisions that make sense for patients' longitudinal care. There needs to be a connection between the medical home and acute care facilities so that rapid follow-up is not only possible, but standard. Through the process of developing this event, our group here at Brookings and a group of emergency physician leaders who are members of the American College of Emergency Physicians have worked to develop several recommendations about how to work together to create an integrated acute care system for all Americans. I'm now going to tell you about these recommendations. These recommendations are not final. Today is the beginning of an ongoing discussion about how to improve acute care. We do not have all the answers. The first group of recommendations is for acute care providers and facilities and provider and facility organizations. The first recommendation is to work to develop acute care specific pathways and protocols. Pathways will help standardize care and bring the best evidence to the greatest number of patients possible. Great examples of this are the protocols created by Dr. Weiler's group in Colorado. Standardizing care needs to be both a national effort and also a local effort to ensure that protocols work for people and make sense for the local medical community and its resources. The second recommendation is to develop systems to manage care for acute care and post-acute care. This may include telemedicine, telephone, or other asynchronous forms of communication. Robust systems should be developed for managing patients after their acute care visit to ensure that patients have their needs met. There should be programs to manage high-cost patients. Acute care systems need to take greater responsibility for patients after the acute care visit. The third is to actively engage patients. We need to talk with patients about their choices and how those choices impact care. People need the right tools to make the right decision about where and when to seek care. We as providers can and should help. The fourth recommendation is to actively engage in delivery reform to enhance value. We should be open to different ways of delivering care that may be more efficient or more patient-centered. State and national medical societies can play a critical role in coordinating efforts and disseminating information. We need to consider not only acute care, but also care across the continuum. Our next set of recommendations is for government and private payers. The first is to expand quality measurement for acute care. We heard a lot about that today. We need more and better measures to understand whether the right care was delivered and whether it was at the right time. Measures should address access as well as patient safety, and we should continuously work to deliver care that is timely and reduce system crowding. The second is that payers and the government need to actively engage acute and emergency care providers, and I think we're seeing this today, particularly in delivery and payment reform task forces. The voice of providers who take care of the critically ill and injured from a variety of settings need to be at the table for health reform discussions. We need not only the voice of academic providers like myself, but also providers who work in rural settings and safety net hospitals. The third recommendation is that payers and the government need to partner with providers to ensure interoperability of health information across facilities. Interoperability is vital to providers' ability to provide cost-conscious care. The final recommendation is around specific payment pilots that may be useful in improving acute care value. New models need to reward providers for the value they deliver and for new services that are not currently being provided, like care coordination. Like I said, these are just some ideas. We have to start the discussion, and we encourage your feedback. One model could be to pay for add-on services such as social work, case management, and palliative care. Another model would be to develop criteria for a connected ED or other acute care facility like an urgent care center, similar to higher payments for patient-centered medical homes. There could be a small add-on payment for developing specific capabilities such as frequent user programs, callback programs, clinical pathways, and other population health management services. Alternatively, we could directly fund the development and sustainment of these value-added systems. Another model could be payment for acute episodes of acute unscheduled care and focus on disease entities where efficiencies can be achieved through these clinical pathways such as heart failure, pneumonia, and cellulitis. Where the acute care provider could potentially prevent a hospital admission through investing time and energy in care coordination. Finally, we need to think about how to replicate the Kaiser model outside of Kaiser, namely through global budgets with cross-subsidization between providers and facilities. In this model, as Jeff pointed out, groups of providers and facilities could receive a global budget for a population, and cross-subsidization would be required for the providers and the facility, where each would share in the upside and downside of each other's budget using a partial shared savings model. Also ideal in this model would be shared governance across the groups. Incentives to provide efficient, high-quality care need to be clearly aligned for everyone. As I said before, these recommendations are certainly not final, but they're really intended to start the discussion. In closing, we hope that you've enjoyed our approach toward aligning payment reforms to optimize clinical care in the acute care environment. Thank you to our speakers and the team here at Brookings for their outstanding commitment to clinical excellence and willingness to take the path less traveled to implement sustainable payment reform. I'd also like to acknowledge the Merkin Initiative for their financial support of this event and thank the Center for Health Policy staff for coordinating this event. Thank you again to our audience for this great discussion. Be on the lookout for upcoming papers that will extend the discussion. Have a great day.